find out. Hold on, how do I turn it back
I
on?
think I need some tape. Just get the.
Yeah.
We're gonna fix the picture, everybody. If anyone's watching, I have
Gaffer
nobody
tape.
watching right
You need
now,
gaffer
so
tape.
we're okay.
Well-
Maybe is there any tape in there? Just slightly, your head's like cut off.
Uh-oh.
That's better. Oh, that's better.
That looks like Lego.
You know what, if I got a, could you grab me a hymnal? I bet if I had something to prop it in
Right
the
here.
front here,
Where's it? Or
then
Bible.
I'd be good.
The
No one is watching.
Amazon must have some sort of a stand you can put that on.
I know, here, we're just monkeying around, there's probably a better way. Thank you, sir. Oh, that's no good. Yeah,
So you might need something else under the little stand in the back to raise it up some more. Maybe another Lego piece or,
all right, I can just sit here and hold
yeah,
this
you
thing.
could, right? There you go.
That's not gonna work. That's really what I need, right like that. Yeah. That looks really
That might do it.
good.
So it looks like just the size of a Lego piece to go under that to hold. And then,
That's good, but I need to keep this from tipping forward. Thank you, I'll take it.
there you go. Between the Bible and the
There.
hymnal. There you go.
Oh yeah, now we're on.
All right, we
And we
good.
have 3 people watching, so.
Cool.
Yeah, you're kind of in shadow because of the light from the
Ah,
projector. But yeah, that works. That's perfect.
And you can play it too.
Yeah. And when it's set to turn off at 9:50, but if you end early, there'll be a red stop button. Just turn it off, the broadcast.
so 9:50 is when it's over, huh? Okay.
It turns off, so whatever you say past 9:50 won't be picked up on the,
Okay.
but you're supposed to be done by 9:45. That's the goal, so.
All right.
All right.
How do you know there's only 4 people on?
If you want to scoot your chair around, right there.
Oh,
Tell
no,
me.
that's all right, I'll stay
You're
there.
good.
I don't care. if
3,
you
we're
want
up to
me.
3 now.
Should I start then?
Yeah, I think you could go ahead and start 9, 8, well, we told people 9.
Yeah, so probably wait
I
3
guess you
minutes.
better
3
wait
minutes.
till
I'll wait 3 minutes, yeah.
Yep.
Yeah, because people will be logging in and
Yep, exactly.
trying to get their
Figure it out.
internet connection going and
Exactly.
Thank you,
Awesome.
Sue. Thank
Oh, I should just check and make sure that I can hear you all right.
Okay.
So let me just put it on here
good idea.
and test that.
So I'll just talk about nothing so you can listen to see if I'm making any sound. Any sound. And we're all socially distant here, huh? Get out the tape measure. Let's see, I think we're about 15 feet away here.
Go ahead.
Good, 1, 2, 3, testing. Can you hear me now? Can you hear me now?
Actually,
That's
it's a little delayed, but I
Yep.
can hear your voice.
Yeah,
so
okay,
you're good.
okay.
Fantastic.
Has to be routed through China so they can take the information and then
Right,
come.
right.
They need this information.
All right. All right, we'll wait 2 minutes to start then.
I hear people coming.
Yeah, I think more people are coming in. Something like 8 people logged in to come here, so so we'll wait for them to get here. Wait for 9 o'clock for people to get logged on at home. Good morning. Gee, Pete, you got all dressed up to come see me, huh? Good. Yeah, right. Hang up the scrub pants, hang up the exercise pants and get all dressed up and go to church. So we're going to start in about a minute. We'll wait until exactly 9 o'clock to actually start. Meanwhile, grab a little coffee. If you think about it, if we didn't have all this technology, everybody'd just be sitting at home,
True.
reading the paper, whatever. watching one of the mega ministries on TV.
Actually, it was impressive that the technology stepped in as quickly as it did.
Yeah.
Even though it was there, businesses weren't using it. Morning, people.
Good morning. All right, 10 seconds. Oh, I see the second hand doesn't work.
Mine says 9 o'clock.
All right, so 9 o'clock, well, we'll get started. So good morning to everyone, and good morning to everyone watching us virtually. I'm glad you could check in this morning and listen to my little presentation about the prominent viruses in the news these days. I'm calling it Going Viral. I had a talk back in December a little bit about COVID-19. I'll refresh a little bit about some of that basic information. There'll be a little bit of science in this. I'd like to have you just get an idea of why some of these things happen, and then we'll talk about the diseases and why things happen, and then I'll try to keep it brief, maybe 10 or 15 minutes, and then have questions. So this is our lecture. I'm going to move out of the way so you can see the slides. Just the state of the art here, the state of the country as of yesterday. About 7.3 million people were infected, and 208,000 deaths, a little over almost 209,000 deaths. By comparison, the flu every year kills somewhere between 24,000 and 62,000. So figure, 30, 40, 50,000 people a year die from the flu, and we'll talk a little bit about that in a second. So what kills people? In both these diseases, these are respiratory and systemic diseases. So they get into the lungs, but they also affect the system. You hear a lot about comorbidities. Other diseases, if you already have heart disease, diabetes, high blood pressure, kidney disease, a weakened immune system, an autoimmune disease, those things are going to make you more likely to die, because when those diseases, if they're stable and then you interrupt them, things can fall apart. Older people are more likely to die, although there is a syndrome in children. It's not very common where their immune systems go crazy and they actually get ill and die. The big thing in flu, a lot of people don't actually die of the flu. Usually they die of a secondary pneumonia. The flu weakens the lungs, and then other bacteria get started in there, and these days with a lot of resistant antibiotics, they often die of a secondary pneumonia or overwhelming sepsis, so the whole body is infected. And then the immune system, if your immune system is bad, you may die from that. And then direct organ damage. That's actually more appropriate for COVID-19. The flu doesn't do a lot of direct organ damage other than to the lungs. The flu viruses are really a lung problem, and then the system fails because of complications. But in COVID, it's really direct organ damage. Now, COVID attaches to organs. It will directly attack the lungs, the brain, the gut, the kidneys, the skin. A little bit about coronaviruses. This was from my last lecture. Coronaviruses have been around for a long time. They don't know exactly when it started because nobody was back there, but they developed, there are dozens of strains. Only 7 infect humans. This is where the president was talking about early on how this is just a cold, because some coronaviruses cause common colds, but this one doesn't. There are 3 serious ones. The MERS was the Middle Eastern Respiratory Syndrome that you may have heard about a number of years ago. That was not spreading as wildly as the current one does. The original the original SARS that came out a few years ago, that was pretty bad. That was easy to get under control. But this current one is apparently a lot more spreadable, which is why we're running into this pandemic issue now. The problem with a lot of these viruses, the flu, the coronaviruses, they infect other species. And these viruses are very unstable. They mutate very rapidly. They're mutating all the time. Some of the mutations are irrelevant. Some of the mutations are problems. And when you get 2 different species of viruses in the same animal, there's all this genetic material floating around in the cell reproducing itself before it forms into a new virus. And sometimes genetic material exchanges among strains. And this is how these bad strains sometimes get started. That's certainly what happens with the flu. every year there's a new flu vaccine because the flu virus has changed. They undergo these minor changes, and sometimes they undergo major changes, and that makes them a bigger deal. The big thing about the current, let's see if this is working here. I don't know if you can see that little red light. The thing about the current SARS, these other ones didn't attach to the respiratory tract all that well. This one attaches to an enzyme called angiotensin converting enzyme 2. These receptors are everywhere in the body, and so this virus doesn't just stay in the lungs. Once it gets into the system, it can attach to all sorts of organs. So how do we prevent? Well, the flu, the best thing is immunization. The immunization itself is not 100% effective, but if everybody were infected or were immunized with the flu, you'd get this herd immunity thing where the vast majority of people are immune, so it's not going to spread around as much. I tell this to patients all the time. They say, well, I'm healthy, I never get the flu, I'm not worried, I'm not going to die. And I say, yeah, but what about your family? What about your parents? What about your friends? If you get the flu, you're going to be spreading it to them. So getting a flu shot is really an altruistic thing to do, even if you don't worry about the flu. The less likely that you are to get the flu, less likely everybody in the community is to get the flu, the less flu we'd have. For COVID, for now, face masks. We talked about this a little before we started. Originally, the original message was they don't work, but the thought was that face masks are designed to keep you from spreading your stuff to the patient in the case of a surgical mask, and it isn't designed to protect us who are wearing them. But then they started looking at this and saying, well, you know, in reality, the mask does stop it to some degree. It reduces the amount of stuff that you inhale. Not great. An N95 mask that is fitted well, that's tight, that doesn't allow any air to leak in around the sides, can protect you. Now, there was no way to get an N95 mask for several months unless you wanted to spend like $150 a piece, but they are available now. The trick is it has to be fitted well. If you buy an N95 mask and you put it on, it has to be, I'm going to show you, I'm going to stand in front of you, it has to be tight around here. And the way we test them, we put them on, we fit them, we make sure that you're not feeling air coming in, and then they spray powder, they spray saccharin into the air. You can also do it with perfume or something like that. If you can smell it, it's not tight enough. You might have to make it tighter, you might have to adjust it around. But that can protect you. But the big thing is if every man, woman, child in the United States were wearing a mask when they're out in public, we could really shut down the spread of this thing in about 3 months. Not too many people are saying that, but if people did, maybe we could do it. Anyway, immunization, we'll talk about that in the middle. There's at least 44 vaccines in clinical trials. There are 91 more that are preclinical. There's a whole bunch of approaches. The two basic ways is they're trying to find a way to get part of the genetic material that makes the COVID receptors, the part that our immune systems would respond to make our cells make these things so they're floating around in our bloodstream and our immune system begins to make antibodies against them. So that's one option. They're looking at a virus vector. They're taking an adenovirus, for example. The adenovirus causes the cold, doesn't kill us. They weaken it a little bit. They put this little bit of RNA into it, and then if you give a person this virus and it gets into our cells and infects us, it starts reproducing the receptors for the COVID, and our immune system begins to make antibodies against it. So that's in testing. The other way is just to inject a piece or take a COVID virus and weaken it so that it can't reproduce itself. I mean, there are a whole bunch of different ways to do it. Will it work? I don't know. The studies are still being done. So, as I said, the viruses, they reproduce themselves using the cell's mechanisms. The virus attaches to a cell. The receptors on the outside of the SARS virus attach to a cell. It opens a hole into the cell, and the genetic material goes inside and reproduces itself using the cell's mechanisms. With the flu, there is an enzyme called neuraminidase that allows the virus to get out. Once the virus reproduces itself, puts a new cell wall on itself. It wants to erupt out of the cell. It needs this neuraminidase to get out because the receptor that's on it, which is called the hemagglutinin, the new ones have hemagglutinin and neuraminidase on them. They call them the H's and the N's. You may see viruses referred to H1N1, H3N2. That's the hemagglutinin neuraminidase on the outside. Hemagglutinin gets it in, neuraminidase gets it out. If they didn't have the neuraminidase, all the hemagglutinins would have it attached to the cell. It would never leave. So what we do is we have medications that are neuraminidase inhibitors. Tamiflu, which is also Tamivir, you'll probably have all heard about. That is an oral medication that, for the flu, inhibits the neuraminidase so that all the virus may get into your cell, it can't get out. Zanamivir is an inhaled one. There's a relatively new one called Peramivir. It's meant to be given intravenously for people who are seriously ill and in the hospital. And then there's a new one, Baloxavir, which works a different way. It inhibits an enzyme that allows the genetic material to reassemble itself, and it inhibits that so that the virus essentially doesn't go anywhere. For COVID, there's a drug, remdesivir, which you've also heard about. Adenosine is a part of the genetic material. There are 4 types of there's adenine, guanine, cytosine, and thymidine. Adenosine is one of them. Remdesivir looks like adenosine to the cell, and what it does, acyclovir is one we've been using for a long time. Acyclovir is another one of these analogs, and it puts a cog in the reproducing material. So the genetic material is being reproduced. This thing sticks in there, and it's like if you have a zipper and you get something stuck in the zipper and it can't go any further. That's what happens with the virus. It stops the reproducing of the genetic material so that it never gets anywhere. The problem is that it doesn't always work great. For herpes virus, the ones that we have for herpes virus work great. Herpes virus is a little bit different. It's a little more stable. But with the SARS virus, sometimes it finds a way around it, which is why it's not like, just give it to everybody and we're going to be fine. It doesn't always work. Now, Regeneron, you've probably heard about this. The president is in the hospital now with COVID, and he is being given this Regeneron's antibody treatment. I don't even think it has a name because it hasn't been marketed yet. Now, what this does, this is different. This is not an antibody. So our antibodies, when we fight something, our antibodies latch onto the thing that we're attacking, and then the rest of the immune system says, okay, there's our target, and they kill it. What this does is it attaches to the COVID receptor, the ACE2 receptor, so that it can't get onto the cell. So it's kind of like, I've got this little thing I'm going to attach up, they put a glove on it, now I can't. Now the trick here is you might think, okay, why don't we just make a whole bunch of those? The problem is that, again, the constant genetic mutations, if they put one antibody on the and you got to figure billions, trillions of these viruses, one of them is going to undergo a mutation that allows this antibody not to stick on it anymore. So they give you 2. The likelihood of the virus having a spontaneous mutation that changes 2 receptors at the same time is so small that using 2 antibodies would be it. And I read a little bit about their research, and they went through thousands of potential antibodies. They generate these antibodies, one in a mouse that's been genetically modified to be like a human, and the other one is in human cells. So I won't bore you with the details right now. That's a little more science than you probably really wanted to have this first thing in the morning. So what are we going to do? As I said, face mask. It should be cloth, like the one I'm wearing, or it can be a regular surgical mask. It needs to cover the mouth and the nose. So I'm going to stand in front of the camera. This is not the way to wear a mask. Okay? If you see people with it, just grab their mask. Don't grab their mask, but ask them to pull it up like that. This doesn't, because a lot of your virus is coming out of your nose, and unless you're a mouth breather, most of it's coming out of your nose. When you speak, of course, it comes out of your mouth. Bandanas are not effective. There's some research that says that that the amount of virus that comes out in the aerosol with a bandana is worse than if you're not wearing anything, because the bandana apparently breaks up the big droplets that would normally fall to the ground and makes them small droplets so they float in the air more. And social distancing. So viruses, when I'm talking now, there's probably some little micro droplets that are coming out of my mouth and dropping to the ground, but there's a lot of virus that's in the air around me, and that's the aerosol. And these viral particles can float around for a while. And the social distancing allows, we figure 6 feet, that's probably pretty close, around a 6-foot diameter in front of me. If you stay out of there, you're probably going to get out of my aerosol. Now, how can you prove this? Chew some mint gum and stand near somebody while they're chewing it and talking to you, and walk closer until you can smell the mint. That's an aerosol. Okay, so that's, you know how oh, you're chewing some gum. Can I have a piece of gum? You know, you can tell. That's because it's an aerosol. When you're talking loud, shouting, laughing, coughing, sneezing, it goes further than 6 feet. When you're singing, 9 to 12 feet. This is why we don't have the choir, because way back there was a choir, I think it was in New England. One person was infected. She sat up in the far right with the sopranos, and everyone got COVID, and one person died. So you won't see the choir singing for a little while yet. This was 1918 Georgia Tech game during the Spanish flu. Everybody's wearing masks. Everybody's wearing masks. Except this guy back here is probably getting a drink. But I don't know whatever you're hearing on TV about masks don't work. You don't need to wear a mask. I don't need a mask. I'll wear one if I need one. Forget it. Wear a mask. 100% wear a mask. Unless you're eating or drinking. If you happen to be in a restaurant, socially distancing, you can take it off to eat or drink. It's not like, I don't want people to be paranoid if they see somebody without a mask and think, oh my God, it's like, it's like typhoid Mary or something coming to me. But reasonable, just reasonable care. If the message from all our leaders at all levels of the country were, everyone, wear a mask, don't argue with me, don't tell me it's your right. It is not your right to be able to hurt other people, because you're not wearing it so much to protect you, you're wearing it to protect everybody else. And people say we have I'm going to get political for a second here, but we have the right to own firearms, but we do not have the right to fire them any place we want. We have the right not to wear a mask except when it's going to endanger somebody else. So if we wear masks all the time, encourage everybody to wear a mask, wash your hands a lot, try to keep distant when you can't otherwise do it. This is going to be the thing that will help us. And I'm hoping that that when the president gets out of the hospital, that he changes his message and encourages everybody to use masks. So that's the background. Now I'm open to questions. If anybody has any. Yes?
I have a couple questions. If nobody else has questions, I got a question. Back on one of your first slides, you said that there were 7 coronaviruses and 4 of them caused the common cold. Is there another type of virus that causes the common cold? If not, and if there are only 4 common cold viruses, then why do we always get the cold multiple times every year?
Right. There are, I forget exactly, probably 100 rhinoviruses, maybe 100 adenoviruses, echoviruses, Coxsackie viruses.
So that's why we're always getting it.
The viruses are, yeah.
Also, just anecdotally, I feel like in the last several years, like when I do get a cold, I feel it lasts longer and it's worse than ever before. Is that true, or is it just in my head, or is it just because I'm getting older?
Just one more thing about that first question. So there are lots of different viruses, and apparently some of these you can be reinfected with the same one. So the same with the coronaviruses, you can have antibodies, but we think it's possible years later to get reinfected, which is why they're worried about the vaccine. If they get an effective vaccine, we might have to give it to you annually, biannually, or something like that. Like tetanus is every 10 years, for example. Your response to what a particular virus is partly the virus itself and partly your comorbidities. When you're younger, your immune system's a little more effective, so there's a little bit of age involved. If you are a tip-top athlete, excellent condition, exercise vigorously, no smoking, perfectly normal health, your immune system's going to tend to be a little bit stronger, but a lot of it is genetic too. What other medicines you're on, things like that. Having allergy problems, so on and so forth.
I do feel like I get sick less often, but when I do, it seems like it takes 3 to 4 weeks instead of 7 to 10 days.
And I probably should repeat the question. The first question was if there are only 4 4 coronaviruses that infect us, why do we get sick so much? And I said that there are just so many different types of viruses that cause colds. And the second was if I seem to get sicker when I'm older when I get a cold, and why is that? So, okay, go ahead.
I have, I think, 2 more questions. I'll save one for last, but you mentioned something about the adenovirus being used. Was that being used in the COVID vaccine?
Yes, the one of the, or maybe, it might be several. I don't have all of them in my head here, but what they're doing is taking a cold virus, an adenovirus that causes a cold that's not going to kill us, and they are weakening it a little bit, and they're inserting some of the genetic material from the SARS coronavirus that produces the cellular receptor, the receptors on the outside, and they're letting the adenovirus make those receptors. So it's not a virus, it's just the receptors. Then our immune system sees this foreign material and develops immunity to it. So yes, they're using an adenovirus to get the material into our cells. If you just inject the material, our immune system is going to recognize it and get rid of it, and we're not going to sustain enough response. You have to give people a very big dose of, if you're just going to inject the receptor proteins into your bloodstream, you'd have to give so much till your immune system responded. So by giving you a little bit that goes into your cells, you're making it, right then, you're generating essentially vaccine inside your body.
So they're just using the adeno kind of as a vehicle. It doesn't, I was just thinking, we know that we've all had the adenovirus, because my daughter had it when she was very young, and I thought, oh, does that mean we have some immunity to COVID? But it sounds like it's just a vehicle.
Yeah, so if you've had an adenovirus, it has nothing to do with COVID.
Okay.
They're using it as a vehicle. And this is actually something that's being done in a lot of other diseases, like they're treating cancer with herpes viruses that have antibodies that attack the cancer. And they inject it right into the tumor. So it's an interesting way to get what you want into the cells, get a virus to deliver it.
And my last question is more a personal question for you as a doctor, not for who you work for, but as you as a doctor, would you trust one of these vaccines coming out? Because I have concerns of how fast it's going, whether they're politically motivated, whether there's pull there, push there. If a vaccine is out this fall, this winter, would you sign up to take it? How confident would you be in its safety?
So the question is, when and if a vaccine comes out, would I be confident enough to take it as a physician? I don't know, because vaccines are tricky. You can see from the slide there are a whole bunch of them being made. As a physician, I would look at the data. It's just like I do with any vaccines I recommend to people now. I look at the data. How effective is it? How does it work? What are the potential side effects? How many people did they test it on? You know, when they do these viruses, you've heard about phase 1, 2, 3, 4. Phase 1 trials, they get a small number of people, maybe 100, maybe 1,000. They give them the vaccine. They see who got sick. If they got sick, was it related? Because when they do these studies, they track people very closely. If I give you this vaccine and you call me a week later and say, I've got a cough, I don't know if you're caught a cold unrelated to the vaccine, but they put everything down there. Then if they see that it happens a lot, and if they can figure out how it may have happened, they say, okay, it's the test material that's doing it. So they give it to 100 people, and everybody's fine. So they get phase 2, they give it to maybe 1,000, maybe 10,000 people, and maybe one person gets something, and you say, well, we can't really tell. What if you give it to 10 million people, and 1 out of 10,000 gets it? That's going to be a lot of people who get this, whatever it is, it's a serious problem. And this is why you can't just say, okay, we got a vaccine, let's give it to everybody. We have no idea whether it's going to be long-lasting immunity. We don't know what it's going to do to you. So this is what I look at as a physician. I look at the data that they have. How well was the study designed? Did they fudge the data a little bit? Did they, the statistics can be affected sometimes by taking one person out, putting another person in. It can change the numbers. When it comes down to it, you look at what the experts are thinking about it. You look at the commentary in the medical literature. So to basically answer your question, if I see that the data is good, that I think it's a well-made vaccine, that I think it's effective, yes, I will get it for sure. I mean, people say flu vaccine. When the flu vaccine is shipped to the office, I say, okay, I'm here. Give me my flu shot. So. Okay. Yes.
In the vaccine studies, don't they not give vaccine to some?
Yeah, they compare it to placebo, because you have to see this group, how many of these people got the disease versus how many of these people got the disease. And if there's a statistically significant reduction in the people who get the vaccine, then you say, okay, it looks like it's effective.
So then, I'm sorry, another question. So then how are they proving that right now? Are they exposing these people in the study to COVID?
Yes, so now when they're testing the vaccine, they're not no, spray.
I'm like,
Sure, they just put them in a room. They send them to a Trump rally. No, sorry. They let them go about their business. Okay, so they'll get people sign up, and they have no idea. It's called double blind. So the people giving it, the people evaluating, the people who are getting it, that nobody knows whether you're getting a placebo or the active substance. And then they watch them for a period of time. They let them go about their business. And when people get sick, they may, some studies, they may monitor them once a week. They may call them on the phone. There's lots of ways to monitor them. How many people are hospitalized? How many people die? How many people got sick? And then if you get sick, they're going to test them and see if they've got the COVID. And so then they compare the people who got the vaccine. Then once you've got enough people to make it statistically significant, they'll break the code. They'll find out which people had what. And they'll say, okay, these people who had this active vaccine, very few of them got sick, and they've got antibodies. And over this side, more of those people got sick, and the only ones who got infected got antibodies, and they can say, okay, this looks effective. Sometimes they'll say roughly equal numbers got sick, and the antibody levels aren't that good, so they say, okay, this isn't working, we reject that one. So they don't spray it. Yeah.
that'd be the best way to test it, come on.
Sure. Back in the days before all the protection laws for subjects, they actually did that with prisoners, poor people. They actually gave them disease. You may have heard of the Tuskegee people, the unfortunate black men who were infected with syphilis, and they just let them go and watched what happened to them. That kind of stuff never happens. My wife is working on a study now. She's not even going to be giving a drug. She's using essential oils, and the hoops that she's had to go through. And she hasn't even started the study yet to make sure that everything's going to be done right and nobody's going to be harmed. It's just unbelievable.
We just signed like a 6-page contract just for the at Penn State Health, just for them to be able to access our daughter's medical records. It's like, yeah, please do look at them.
Yeah. So, yes, next.
I have a question about the contact list, or how is that being done? Because it seems very sketchy.
Yeah, so the question is contacts. If someone gets sick, contact tracing. I have an idea. I only know in general how contact tracing works because we've reported sexually transmittable diseases for years. We report mumps, we report meningitis, and a number of other diseases. And when that works, there are people in the Department of Health. In this case, they probably have hired a lot of people to, if you have the information about the person who's sick, name, address, phone number, email address, they'll contact them. They'll say, this is the Department of Health. You've been identified as a person with COVID-19. You got infected on this particular date. Can you tell us about what you were doing that time? Okay, so how many people were there? Can you remember anybody's names? Where were you? If you're in a public place like a restaurant, they'll call the restaurant and they'll say, we'd like to have you check your receipts from that particular night and get the people because we want to contact these people. How many people got those? So it's very time consuming and very tedious. So if you got sick with COVID and you happen to be down in a restaurant, the day that you're started to get sick, they'll want to contact all those people, and then they'll want to contact all the people those people were in contact with, find out how many people got sick. This way they can find out first of all, how many people there are, they can find out how bad it was, and that sort of thing. So that's basically how it works. It's extremely tedious and time consuming. And a lot of times you don't know. If you go to a big thing, there's a whole bunch of people over in the Tanger outlets right now looking at cars. None of them have masks. If one of those people gets sick, they don't know who those other people were, I was there to get coffee and I wanted to say, but they'd have probably laughed at me, probably. Not that I really cared, but I wanted to get over here, so. Yeah.
We were in Canada when the SARS outbreak was.
The first SARS.
And that seemed to just disappear after a couple of months. They went through the hand washing and that type of thing, but there was really no mask. It just sort of vanished.
Okay, so he says he was in Canada when the first SARS came and went away pretty quickly. There were no people wearing masks and so on. That one was not as infectious as this one. That one apparently did not and I'm speaking not as a microbiologist here, but as much as I know about these particular viruses, that one was not as infectious. That one didn't get you as sick as quickly, and apparently didn't spread as well. So it was able to go away. The thing that when I first heard about this being in China, and I thought, oh man, my thoughts were, I wonder how infectious it is. I wonder how much it spreads. I wonder where it came from, what's going to happen next. So I wasn't worried at all. In fact, I had a bunch of N95 masks at home, and one of Tasha's coworkers had family in China, and they couldn't get masks. So I said, here, take these and send them to them. Little did I know. You know, I didn't realize, I thought it was going to be like the other SARS. It's going to be a little bit of a thing, but turned out to be a lot worse. So it's like, you know, you get flu every year, people get complacent, and then you get a really bad one that really infects, and you just don't know until it gets here.
But SARS still exists. But it doesn't-
That virus is out there, but, and I think it pops up here and there. I'd have to go to the World Health Organization website to try to find that information, but it's not as big a threat.
They never came out with a vaccine or anything.
No, because it hasn't been that big a deal. You know, Ebola is another example. Ebola is a horrible, awful disease, and they have a vaccine or two available now, and they had to basically shut down areas. And when people came to the United States, like they ended up in the hospital in Texas, you know, they didn't realize. I mean, they just went ballistic about putting because Ebola kills you. I mean, Ebola is a horrible disease. That still pops up every once in a while, and the World Health Organization just gets on it. They just shut the place down and don't let anybody go anywhere. You know, so we can't do that. I mean, we tried shutting down to some degree here, but you just can't shut down that way when the whole country is affected. So, yes, sir.
Question from online. Is it safe to eat indoors in restaurants right now?
Okay, is it safe to eat indoors in restaurants right now? First, I want to clear up one thing. You don't catch COVID with your hands unless you touch your nose. So if you pick up the virus from somebody coughed onto and then you blow your nose, you wipe your nose, you rub your eyes, pick your teeth, whatever, that's the way you transmit it. But if somebody's coughing on your food and you eat it, that's not the way to catch it. I wouldn't advise it, but that's not the way to catch it. So is it safe to eat in a restaurant? Again, if you're wearing a mask going into and out of the restaurant, if the servers are all wearing masks and the tables are distant, now you can't really see here, but each of these tables is at least 6 feet from each other. All the people are, everyone here is at least 6 feet, some are more like 12 feet from each other. If they set up the restaurant so that the tables are far enough apart, if there's adequate ventilation, which is another thing, and you put your mask on and you just basically talk among your small group, it's reasonably safe, reasonably safe. Now, you know, you have to weigh the mental health problems of staying locked up in your house for months at a time versus going out and getting out in the public. We are social people. Oh, that's a good idea, shut that off. We are social people, you know, we need to be among other people, and so it's reasonably healthy to be out there, and I think that the relatively low risk, if you exercise some reasonable precautions versus the benefit of being out in the public is probably worth the risk. The next question I'm sure is going to get, I know Pastor Stephen wanted to know this, I think, what about church? And I would say the same thing. I think that if we were to set it up so that families, couples could be grouped together, but if you had every other pew and maybe only 2 or 3 seatings per pew and maybe reserved your spot like they do on Tuesday evenings, you could probably safely get away with coming to church. You couldn't sing, but you could talk, you could say prayers, you could have music playing in the back. You could probably have soloists up in the front or even a small group like we've had online, but I think it could be done safely with precautions. Same with going out to eat at a restaurant. And I have gone out to eat at restaurants since the restaurants have become available. Basically, you know, looking around, making sure that there's precautions. Same with visiting people. Ideally, if you're visiting, you would wear masks when you're visiting, and then when you're sitting further apart. You probably, we love to have parties at our house, and we keep saying, I can't wait till we're able to have, a dozen people over for a party. Now we can have 2 people maybe at most. So, yes, sir.
Without a vaccination, do you think this virus will dissipate over time?
So do I think that the virus will dissipate over time without a vaccination? It could, but it would be devastating to the world. If they were unable to produce a successful vaccine or a reasonably effective medication that would be widely available and easy to take, this would eventually settle down when pretty much everybody in the world got infected and either survived or died. So, is it Sweden? Or was it Norway? I forget which the one. Sweden, yeah. So the Minister of Health in Sweden decided, we're not going to do any of this stuff. We're just going to let natural herd immunity develop. The mortality rate was extraordinarily high, but now the attack rate is very low. It killed a lot of people to make it go away. So if we're willing to say, okay, it's okay that millions and millions of people worldwide die of COVID-19, those of us who survive will be okay. I don't think most people want to say that. So, yes?
I have a question. I read some article, like in June or something on this topic, that they looked at somebody who said that the early deaths, 76% of them were respiratory related. 20% of them, almost 10% of them, were blood clots that occurred in younger people. Usually that was one of the things that, I haven't seen anything about the blood clot thing.
Okay, the question is about deaths. Most of them are respiratory. Some of them are related to blood clotting. So this virus, I think the scientists studying the blood may have a better explanation than I have, but it has ways of affecting blood clotting. One of the things it can do is it can cause little tiny clots in the fingers and toes. There's a rash that develops and that sort of thing. Our clotting system is also very complex. I always love my hematologist friends because I would say that was one of the things I had to work really hard on when I was in medical school, was learning about the blood clotting systems. But it is very complex. We have genetically, our genes give us certain levels of various clotting factors, and depending on how our body responds to the infection, what our antibodies are doing, our clotting factors can go up, can go down. And so, and also it affects the internal lining of our arteries. So clots can sometimes form more easily. So that's part of the reason. And people can get large blood clots, they can get small blood clots. The small blood clots can damage various organs little by little.
Well, I think her point was that the reason why so many of the younger people who are so healthy would die, and they had not been thought. They were saying, well, I don't have respiratory problems, I don't have to worry about this. But then blood clots.
Yeah, some of the young people die of the clotting problem. There's a syndrome of children that involves a lot of the blood clotting. I don't think it's well understood at this point. I don't personally have a lot of information. I've been watching the literature on that, and I don't think it's well explained yet. But again, it's one of those things they're working on. I mean, if you're a researcher, if you're a microbiology researcher, this is fascinating because you're learning all sorts of stuff that is new.
Is there any kind of dose dependency studies on?
Dose dependent.
Yeah, I mean, some certain number of viral particles per.
So so the question is, what's the infectious inoculum level? So how much virus do you need to get it?
Right.
Yeah, I don't have that answer. If you get a few viral particles, you probably won't get infected. I think you need a certain amount, but I don't know what that actual number is, Pete. I'm sorry, I don't know that.
So when they say somebody's asymptomatic, that just means they've done the test, they haven't developed the disease yet. If he came back a week later, 2 weeks later, they would have the disease, or they would not develop it.
Yeah, so the question, right, the question is about the word asymptomatic.
Yeah.
So there are a lot of people who have turned out to have antibodies and they had no idea that they were ever sick. So for those people, for reasons that are not totally well understood, the virus got into them and they were able to get it under control. Was it because they didn't get a large viral inoculum, or was it because they've got great immune systems? Don't know that. But the asymptomatic people we worry about is the people who are infected and haven't shown signs of illness, because you can be without symptoms for 4 days or so before you get sick. And in the meantime, if you're not wearing a mask, you can be spreading it. And this is why we talk about masks all the time. it takes a while for the virus to start infecting your cells, to start regenerating itself, and for your system to start reacting to it. There's some other studies that you won't read about too much. There are some companies that are studying sewage. We know that it's a standard way to analyze viral infections by looking at the sewage and watching the viral particles that we're shedding in our stool or urine. And they can take a sample of sewage from various areas, and they can do basically a count, and they know what areas are draining to that particular sewage area. They can say, okay, this indicates that X number of people are probably infected with this particular virus. And I read an article about this, several months ago, that there may be 10 times more people infected with COVID than we are aware of, which again is a reason to wear masks, because there could be somebody in this room right now with COVID virus in them who isn't sick and may never get sick, but you can be spreading it to other people. Now everybody's going to back up a little bit more. No, just kidding.
Is there a test for antibodies then?
Yeah, so
So if you got, I mean, there was an antigen test, right, first.
yeah, the antigen test is,
Developed that you look and say, do they have the antibodies?
right, so the antigen test tells if you have the virus right now. The antibody says whether you've been infected with it. The great thing would be if we had widespread antigen and antibody testing available. So if everybody could get an antigen test, get tested for COVID and get presence and for antibodies, then we would have an idea how far this is spreading. We don't have that information. That from a public health point of view, that would be really, really good to know. They're working on being able to get better and faster tests. Some of the faster tests have a high false negative rate. So that's okay, but if you keep getting tested on a regular basis, and you're negative one time, you may be positive the next time, but it would be helpful to know. A lot of people are thinking, like with the president, he says he got tested every day. Well, if that's true, let's assume, for the sake of argument, that he does get tested every day, and they're using a rapid test, he could have been negative for a while, and then he's positive. Maybe he just happened to have enough virus at that point that you could pick it up. So the tests, a lot of people sort of misunderstand about tests. Tests are not 100%. There's a certain range. Somebody will come to me and say, I want to be tested for this, that, and the other thing, and they don't really understand it's not a yes or no sometimes. It's a kind of a maybe or looks like. But if we could do antibody tests on everybody, we could get a sense of where it's been. At this point, we don't have that information. It'll be very costly, but I suppose we could work out a way to do it. Yeah.
Speaking of tests, there are lots of different tests that are available, designed by lots of different people. Is there any way of knowing that people will talk about openly what are the most effective tests?
So a lot of different tests, and do we have any way of knowing which are the better tests? Yeah, so if you're a lab scientist or a lab physician, you probably have a better idea of which ones are good. I'm not up on every single test and which one's available, and I don't even know what kind of test is being done. My wife and I got tested before we went to Aruba, and we got tested when we got there. I bet it's 2 different types. We were negative both times, but I don't know what the limits of those tests were or the technique. The tests that I use on an everyday basis, we know what's going on with them, and our lab will tell us if they've changed the parameters, or they've changed the reagents, or they've changed the company they're getting it from, and we know what the limits are. But with these, they're just out there, and we don't really know. I'm sure somebody knows, and I'm sure that information is available. You just have to do a little research to figure out. But you need to know who made the test, and then you can check and see the process and see what the rates are. So yeah, some of them are going to be, there's a false negative rate for everybody. I don't think there's false positives, to the best of my knowledge, with any of them. I think, but the false negative rate can be, some of them have a very low false negative rate. Some of them have a little bit higher false negative rate. And then the other thing that you have to consider is the method of testing. If you take that little swab and you just stick it in your nose, you can get a lot of negative tests. You've got to stick it all the way back to the back of the throat and get a good swabby sample and get a lot of mucus on it in order for it to be an adequate test. It's like when I do a throat test for strep in the office. If I don't get that swab on the tonsils, if I just kind of stick it in, rub it on your tongue, and it's negative, that doesn't tell me anything. So, any other questions online? We have about a minute before this thing's going to go off. Okay.
That was it.
So if anybody's still online, I understand this is being recorded, so if you want to see it again, or if you have nothing better to do than to watch this again, or somebody else wants to see it, I think it's going to be available in the Derry's YouTube channel and Facebook. Any other questions from anybody here? Nothing else online?
Nothing.
All right.
Thank you very much, Tom.
I think we're done. All right. To stop recording, yeah. Whoop, whoop, whoop.
Don't want that.
It's probably,
Come back to me.
whoa, stop broadcast, stop, that red stop, that was.